Hi, this is Sheybani. I'd like to describe a case of a patient with Marfan syndrome, dislocated cataract, and glaucoma. As you see, we place a dispersive viscoelastic, especially in the area of recognized zonual weakness, in order to prevent vitreous from coming forward during the case. Here we're using a Kulin hook to inspect the area of zonual weakness in order to determine if we can go ahead with routine phacoemulsification or if we need to suture a capsule tension segment. The capsulorhexis is performed leaving enough of a lip in case we do need to suture tension segment in that area. A cohesive viscoelastic is used in the area of zonual weakness just beneath the anterior rhexis in order to, one, keep the vitreous back, and two, to easily dissect the cortex off of the capsule. The hydrodissection is then performed as per routine, and in this case we're performing a divide and conquer technique. The technique doesn't matter as long as you perform a zonual-friendly phacoemulsification. Once we get our initial crack, we then will remove the heminuclei, and we're constantly watching that anterior rhexis to give us clues whether or not the capsule is coming toward our phacotip. If it does, we can place a dispersive viscoelastic in that area. The cortex is then removed. We remove the subincisional last, and we've refrained from placing a capsule tension ring until the end, and essentially in order to prevent us from trapping cortex when we do. After the tension ring is placed, we then place the intraocular lens, and we notice that the rhexis and the bag are completely well centered and stable. We'll then turn the patient's head and rotate the scope in order to place an eye stent. Here, this patient had mild open-angle glaucoma with pressures in the mid-20s on one medication. When we're placing the stent, we're looking to make sure that we're into Schlemm's canal, and after it's placed and we release the injector, we see that there is reflux coming from the lumen of the stent. After removing the remaining viscoelastic, we're going to carefully dry the wounds to place Reschur sealant. I like it in these cases because any egress of fluid could cause a hyphema, which could eventually even block the lumen of that stent.